Now the next speaker is Management of Dry Eye in Cataract Surgery, Dr. Elankumaran Pasupathi.
Thank you, sir. Sorry for this thing. I have another session in the other hall. From biometry, we are going into something which we used to feel even more light or even more less. When I was a resident or in the early part of the practice, we didn't even know about this concept of dry eye developing after cataract surgery. But of late, this is the main complaint that we face from the patients. What is this? Usually, it starts on the very first day of doing the surgery, increases till the 7th day, and then continues for around 4 to 6 weeks and automatically reduces. This is the normal course of any of mild dry eyes in case of cataract surgeries. However, why is it so very important? Look at these two studies, which were released around 2017, 2015, something like that. 75 to 85% of the population presenting for cataract surgery did not know that they had dry eyes. These are the patients who are going to say, your surgery created this problem. So then that was very important, and a surgical society, ASCRS, started giving a nomogram for a medical problem. It had to go down to that level. And how should a nomogram be? It should be consensus. Everyone should have a consensus. Could be easily incorporated into practice, reduce the chair time, and then of course, for all this to happen, it should classify whether it's visually significant or not. Now, what was dry eye causing? Not only IOL problems, usually with the axis, sometimes with the power also, but even after putting in a very good IOL, very good surgery, it used to cause a vision problem, and sometimes like this, infections which are happening because of dry eye. Hence, this particular talk is divided under these headings: pre-operative, per-operative, post-operative, and what is my preferred choice of drugs. Let's go to the algorithm which ASCRS had proposed. This is the algorithm. Non-invasive, can be repeated if need be, but most importantly, it is an idiot-proof, meaning your receptionist or even your optometrist can do this and still you can save a lot of time instead of getting around investigating. The first thing that has to be done is, of course, measure the IOL parameters, that is biometry. Why? Particularly if you're doing a non-contact, that is optical biometry. Why? Because once you touch the cornea, you cannot use an optical biometer. At least for how long? 2 hours at least. So if you do an applanation, put some drops, do not do optical biometry immediately. Next question is, give these people, okay, when you're doing that optical biometry, you can look at the Myers and decide whether this person has dry eye. With just that itself, you can decide that. Next question. Next, give him a questionnaire when he's sitting outside, ask him to fill it. They propose speed 2 questionnaire. Speed modified at that time called speed 2. But what I use is an OSDI questionnaire. Any questionnaire what you have can be given to the patient. He will fill it up and then he will come into your office. The next step, what they said, is practically impossible in India. What is this? They have asked us to measure osmolarity and MMP9, inflammatory mediators. What I do instead, this is practically not possible by a clinician, only big institutes can do it. What I do instead, all of us know that the normal tear film height is around 0.15 to 0.25. So anything lesser, anything more, definitely consider as a dry eye. Look at the meibomian glands. Even if you don't have a meibographer, you can just use a simple autorefractor or any other machine and see the quality of the meibomian gland. After this, the most important, LLPP, look, lift, pull, push. Look for any meibominitis, blepharitis or something like that. Lift the lid to see if there is anything behind. Push the lid so that the meibomian glands, how is that expression? Pull the lid to look at the laxity. Along with that, look at this pooling, look at the staining. This is the next step. Now from here, we classify whether there is dry eye or not. If there is no dry eye, go ahead with the surgery. If there is dry eye, further etiology aspect, neuropathic, neurotrophic, and most importantly, visually significant or not. How do we decide this visually significant or not? Lot of things, but this is what I look at it. When you're taking these Myers, if there's any change, that's number 1. Number 2 is staining. Number 3, very importantly, changing of the keratometric value with every blink. If this is happening, you're not able to get a good keratometric value, then definitely this is a case of dry eye. Visually significant dry eye. Visually significant, wait. Non-visually significant, go ahead with the surgery. If you have to wait for a visually significant dry eye, how long do you wait? Minimum 4 to 6 weeks. Treat this patient. After 4 to 6 weeks, take up this patient for surgery. Do not rush with the surgery. You will have all these equipments, but then I would like to you go for a multimodal use, that's a tear check, which is used in the clinical side. That's what I have. Peroperatively, what do we do? That's a new technology, surgically temporal ocular discomfort syndrome. That's a new technology that's used because of the transaction of the nerves, it can happen. And how do you prevent this? Well, it could be because of the incisional damage, so reduce the size of the incision. Most important, more important than that, repeated irrigation and drying. Avoid this. So how do you avoid it? Use a viscoelastic on the cornea. Do not keep irrigating it. Reduce the eye drops. What I do? 2 times paracaine eye drops, 2 times povidone eye drops, and 3 times dilating eye drops. That's all. Not more eye drops are used. Reduce the surgical time. Reduce the surgical trauma. Look at it. Flax causes more dry eye than a regular phacoemulsification. Of course, reduce the incisional thing. This is per-operatively what you do. Post-operatively, I'll just skip this video because of the lack of time. I think I'm in the last 2 minutes. Post-operative regimen, now comes the question. What is the things to be used? Question number 1, should we use lubricating drops for all these patients? This is a study that said group D, where a lubricating drop carboxymethyl cellulose was used, did better in all parameters. So take home message, use lubricating drops for all the patients undergoing cataract surgery in your post-operative. Second, using cyclosporine, I'll just minimize what I'm going to tell here. When should you use cyclosporine? Stage 2 dry eye onwards only use cyclosporine. That is what this study said. Third, all of us who have used dexamethasone before and now we are using prednisolone acetate, we know this. Which is better? Again, this study said dexamethasone caused less dry eye. Fourth, should we have to use an NSAID? Answer, no and yes. Meaning, no for most of the patient, only when required use it, and if possible, use it only once a day. So what do I do it? I use these formulas to, of course, even dry eye things showed. But one important thing what I do, even if the patient is stage 2, I'll treat him as stage 1 when I'm doing cataract surgery. Stage 3, I'll treat him as, stage 2, I'll treat him as stage 3, stage 1. Meaning one step before is what I do. Last couple of slides, I'll rush through it. Which is the, even if you do not have all these fancy things, this is the Asia Pacific Dry Eye Society with just a fluorescein strip. You can diagnose what is the kind of dry eye and start treating this patient. So it doesn't mean that we should leave it. And here is my MGD if it is there. Stage the MGD, that's the classification. And what do I do? Stage 2, this is the cutoff for me. Again, I use a heat compress. Anything more than stage 2, I would like to use an IRPL, treat this patient, and then take up for surgery. Now, finally, what is the medicine to use? We know that dry eye disease is a syndrome, multifactorial. So again, multifactorial thing. But certainly we'll talk of tear drops, lubricating drops. We use what is called as a multimodal acting drop. You can see here, it's only hyaluronic acid, which has multiple mode of action, at least 4 different types. Rest of them have lesser. Similarly, the next slide also proves the same. So my choice for a lubricating drop in case of dry eye in cataract surgery would be hyaluronic acid. Thank you for the opportunity.